Hello everyone, and welcome Thursday Night Live. We are so excited to be here, and let me introduce you guys to the speaker of the night. So today we're introducing Dr. Shailesh Khode, a consultant snoring sleep apnea ENT surgeon based in the UAE with extensive experience at NMC Specialty Hospital, Cleveland Clinic, Abu Dhabi, and Khoo Teck Puat Hospital in Singapore, where he received multiple excellent patient service awards. He holds international qualifications in the US, in Europe, and in UAE, and has contributed to numerous publications and global conferences. With over a decade dedicated to sleep apnea management, Dr. Khode has completed advanced fellowships in sleep surgery in Singapore and sleep breathing, Rome, New York, and Mexico. He currently serves as program coordinator for ISSS 2026, which is going to happen in Mumbai in February 2026, if you guys are listening to this, and co-director of the sleep apnea surgery Cadaver course in Dubai. Today's topic is drug-induced sleep endoscopy, DISE, a compass for personalized interdisciplinary OSA care. We don't have enough surgeons and sleep doctors who come talk to us. So I am so honored to have you on Airway Circle stage. And our audience, it's huge in myofunctional therapy, but we have several dentists and orthodontists, and it is multidisciplinary. We have everything, but we need to hear more about you guys and understand when DISE is necessary and what exactly you guys are looking for. So thank you so much for accepting my invitation. Did I miss anything?
Thank you. That's wonderful. Thank you for your kind introduction.
Thank you. You may mention this at the end. However, do you mind talking a little bit about the meeting in Mumbai real quick?
Sure.
All right. Tell us about when is it, who is invited to come.
Okay. It's a great honor and to introduce to say that first time it's happening International Surgical Sleep Society meeting, first time outside the US in the Mumbai, India, and in the collaboration with the Indian Surgical Sleep Society. It is a great bonanza and the gala meeting in which we are all inviting the faculties from all over the world, not only the sleep surgeons, but we are also inviting the interdisciplinary team. We can say that the dentists are coming, pulmonologists are coming, speech therapists are coming, the respiratory therapists are coming, even the neurologists, cardiologists, and we are organizing a lot of instructional courses, not only about the sleep apnea surgery, DISE, even oral appliance, and we are also welcoming to have an instructional course about the myofunction therapy, and a lot of talk, a lot of interdisciplinary discussions, panels, and it is great to welcome you all to Mumbai in February 2026.
Yay! Thank you so much.
Thank you very much.
You are welcome to share your screen. You guys might see me looking down on my phone. I am sharing in over 30 groups that we have. I'll be inviting some more people to join this. If you're watching this live, thank you for being an Airway Circle member. And for everybody else watching this on a Thursday, make sure you join the directory. Airway Circle directory. So go to airwaycircle.com, click on directory, and just click on add. So you can add your own listing. And we have over 700 professionals already worldwide, and there are over 3,000 patients searching the directory every single month to be able to find you. So help us help you. Thank you. The floor is yours.
So, Mr. Ananta, can you see my screen?
Yes, it is absolutely perfect. We can see everything.
Perfect. So first of all, I would like to thank Airway Circle team and Dr. Renante Nehame for giving me this opportunity to share our ideas about drug-induced sleep endoscopy. Today, I'm gonna talk about how this DISE is called as drug-induced sleep endoscopy can help us to personalize the treatment plan for the obstructive sleep apnea patient, and also help us to activate the interdisciplinary approach in the management of obstructive sleep apnea. So I don't have any to disclose and no conflict of interest. So let's quickly go through. Obstructive sleep apnea is the complex multifactorial syndrome. In the last 2 to 3 decades, the prevalence has been increased exponentially. And when we are talking about the pathophysiology trait of the OSA, it varies from the age, gender, associated comorbidities, and also the psychological status of the patient. When we are talking about the economical and social impact of the OSA, as per the consensus, almost 1 billion population is suffering from obstructive sleep apnea. And if you go to the literature, almost 40 to 50% of patients suffering from cardiovascular disorder having obstructive sleep apnea. And it gives a significant economical impact, around $150 billion in the US in terms of accidents, consumable, and the healthcare. So when we are talking about the comorbidities, if you go through the comorbidon of this, you can see that the obstructive sleep apnea is associated with the COPD as a overlap syndrome, asthma. It can go with the cardiovascular disorder, hypertension, type 2 diabetes malignancy, type 2 diabetes. Even the malignancy, head and neck, as per the literature, almost 50 to 60% patients diagnosed with the malignancy have obstructive sleep apnea. In advanced cases, it goes to up to 90%, and at the end, it goes with the death. So let's quickly go through what is the definition of apnea. It means there is a complete cessation of the airflow for at least 10 seconds during sleep. When it is obstructive, but there are respiratory efforts called as obstructive. When there is no respiratory efforts due to the lack of brain signal is called as central. And mixed means when at the beginning there are central means there is no effort, but it end up with the obstruction and respiratory efforts called as mixed obstructive sleep apnea. What is hypoapnea means there is a reduction in the airflow by around 30% for at least 10 seconds with the desaturation of oxygen around 3 to 4% with evidence of arousals. When any patient having BMI 30 kilogram per meter square with hypoventilation, wakefulness, with partial pressure of carbon dioxide is more than 45 millimeter of Hg is called as obesity hypoventilation syndrome. Now come to the pathophysiology. All of you know that the obstructive sleep apnea mostly responsible for the hypoxic event lead to the chronic inflammation, sympathetic overactivity, and endothelial dysfunction. This leads to the hypertension, can go to the stroke, transient ischemic attack, or acute myocardial infarction or congestive heart failure. Or also it leads to the atherosclerosis, obesity, renal disorder, type 2 diabetes, and definitely it affects the quality of life of the patient. It also responsible for the sudden death and one of the known cause for the road traffic accidents. Now, when we are talking about obstructive sleep apnea, initially, or I can say a couple of decades before, it was mainly focused by the pulmonologists. It's called as a medical disease, but overall period of last 2 decades, I can say that it's become a multidisciplinary approach in that OSA is managed by the dentist, I can say the orthodontics, by coming up with the oral appliances. Even the speech therapist has a significant role to provide the treatment in terms of myofunctional therapy, not only just to strengthen the muscle, but also helpful to improve the outcome, surgical outcome of the patient. Pulmonologists, when we are dealing with the overlap syndrome, cardiologists, when we picked up some arrhythmias, some tachycardia, bradycardia during sleep study, even those patients having a central disorder, we have to involve the neurologist. Dietitian definitely has a significant role because OSA is going parallelly with the BMI. Bariatric surgeons, of course, come into the picture when we are dealing with the morbidly obese patient having severe obstructive sleep apnea. We need a bariatric surgeon. Nowadays, the GPL-1 is coming into the picture to reduce the weight. Nursing staff, of course, it's pivotal whenever we are dealing with the patient in terms of the compliance, CPAP. We are looking after the post-operative care and considering the sleep apnea without biomedical research team, without focusing how we can contribute more in the management of obstructive sleep apnea, it is not gonna complete. And last but not the least, I can say that the ENT surgeons also have a role to look after the upper airway obstruction, to take care of upper airway, to see if any way we can help to make the patients better and reduce the comorbidity related to the obstructive sleep apnea. Now, how we evaluate the patient? Of course, we have to go with the comprehensive sleep study or history, followed by sleep questionnaires, mostly subjective, detailed physical examination, general and the systemic as well as the local examination, level 1 or level 3 sleep study. For those patients who required upper airway assessment, we can perform the dynamic evaluation by drug-induced sleep endoscopy, which is going to talk soon. And of course, some patients we require the radiological evaluation. What are the symptoms we come across? There are the nocturnal and the daytime symptoms. The nocturnal are the snoring, witness apnea, choking, some bruxism, reflux, nocturia, especially in the pediatric age group. Daytime, excessive daytime sleepiness, morning headache, neurocognitive impairment, some psychological factor, and also sexual dysfunction. So when we are going through the detailed history of the patient, we have to consider the patient age, about their occupation, do they have a night shift, are they a driver, about their dietary habit, their social, smoking, drinking, BMI, of course, we have to check on that part during our first consultation. And the neck girth, we have to do very routinely. That is one of the suspicious factor we can consider when we are dealing with obstructive sleep apnea. Along with that, in a first consultation, I would suggest we have to take the blood pressure if there is any family history of blood pressure, oxygen saturation, especially in the women's, we have to really think, are we dealing with the premenopausal, menopausal, or the postmenopausal woman, because the incidence of the OSA is increased every year from perimenopausal to the menopausal by 3 to 5%. Psychological factor, it's very important to understand patient psychology before we deal with obstructive sleep apnea. Hypothyroidism, it also has a significant impact in the management of obstructive sleep apnea. And also, when we are dealing with the history, we need to know that does patient having any breathlessness problem, any palpitation, excessive sweating, or any unexplained hair up. Accordingly, we can involve other subspecialty. All of you know that in terms of the sleep questionnaires, we always ask Epworth sleepiness score. If the score is more than 10, 11, we consider patient is suffering from some sleep breathing related disorder. And also we introduce the stop bank score. If the score is more than 3 to 4, it's considered as intermediate. To more than 5, consider the high risk of obstructive sleep apnea. In the first consultation, as a ENT, we do the awake flexible nasopharyngoscopy examination to understand any obvious static obstruction happening at the level of nose, behind the nose, or upper airway. Static obstruction means, as you can see, there is a quite deviated septum, concha bullosa, hypertrophic inferior turbinate. This is the inferior turbinate. You can see the maxillary crest. Even the nasal wall area, we have to check on that. In the pediatric age group, especially, we are looking for adenoid hypertrophy, hypertrophic tonsils, even the lingual tonsil, which is sitting at the base of the tongue, that is responsible for the collapse at the level of orohypopharynx. Even most of the ENT, we routinely missed the very important finding, that is a high arch palate, which is responsible for not to keep the tongue in the mouth during sleep. That's why it fall back. And because of the high arch palate, tongue is not sitting, it developed the weakness in the muscles, and that is all responsible for the hypopharyngeal or the oropharyngeal collapse. And of course, the microglossia. Now, when we do the sleep study, ideally we should offer the level 1 sleep study, in which we perform that one in the hospital, monitored by the technician. However, considering the high demand and the requirement, even the level 3 sleep study is also adequate enough to get the information about the obstructive sleep apnea. In case we are suspicious about the central apnea or other sleep breathing disorder other than obstructive sleep apnea, we may consider level 1 sleep study. What are the common parameters we see in the polysomnography, that is the AHI, when the total number of apnea, hypoapnea scored is more than 5 per minute is considered as obstructive sleep apnea. We also need to check the oxygen desaturation index. AHI and ODI should go parallel to each other if there is a significant discrepancy in terms of AHI is, for example, 50, but oxygen desaturation index is 80 per hours, it means there is some issue related to the lower airway. We might be dealing with the overlap syndrome, means COPD. In that case, we need to involve the pulmonologist. And when we define the severity, mild means when the AHI events 5 to 15, moderate 15 to 30, severe more than 30. Central apnea, definitely we have to check it on the sleep study. There, like a watch pad is one of the device can help us to pick up the central apnea. Even the Knox can help us to pick up the central apnea. ResMed doesn't pick up that one. When there are 5 or more events, is considered as a significant, and if the central events are more than 50% of the apnea hypopnea, means AHI, is considered as a significant event of central sleep apnea. To elaborate more beyond the AHI, the European Respiratory Society and European Sleep Research Society, they come up with the 2x2 table on the basis of the symptomatology and the end organ impact. And they grade the patient, divide the patient into these 4 groups, that's A, B, C, D. A means patient having mild symptoms of the obstructive sleep apnea and the mild end organ impact, having the better outcome, as compared to the D category having the severe symptoms of obstructive sleep apnea along with the comorbidities like uncontrolled hypertension, recurrent arterial fibrillation, heart attack, diabetes, having the poor outcome and the prognosis. So selection of the patient for the treatment depends on these categories. Now in the last 4 decades, the positive airway pressure or BiPAP is considered as a gold standard treatment for the obstructive sleep apnea by using the different type of mask, nasal mask, full mask, nasal pillow. But unfortunately, somehow the compliance with the CPAP machine is around 30 to 40%, even after there is a significant evolution in the CPAP machine. There are a few factors which is responsible, like some patients, they don't like mask. Some patients say it's too much pressure to be delivered to me. Some patients say it's very difficult for me exhale out because of the pressure changes. They said my mouth is very dry in the morning time. I cannot tolerate that. Even it make my throat dry. They said even I put the CPAP, I still snore, or I still feel tired even after using the PAP machine. Or they said it gives me belching in the middle of the night. It disturbs my sleep. So the compliance with the CPAP is dropped down. What do you mean by compliance? If someone is using the CPAP more than 4 hours in night, 5 nights in a 1 week, around 25 nights in a month is considered as the optimal utilization of CPAP. These are the few factors. So whenever there is a poor compliance, then we have to think about it, how we can help the patient. And whenever it comes in terms of the upper airway management, we have to think in a 3-dimensional way to understand what exactly happening, why patient doesn't have a good compliance with the CPAP, or why patient having a severe obstructive sleep apnea, or what are the other factors responsible for the collapsibility of the airway during sleep. So here come the role of the drug-induced endoscopy come when there is a no good acceptance of the medical treatment, or when we are thinking about to predict how would be the surgical outcome, to give the realistic expectation to the patient, or to select the patient very carefully, depends on the collapsibility. And on going through a detailed sleep study history, we can offer some targeted treatment as per the finding. And when we are thinking about surgical treatment, means indirectly we are remodeling the upper airway so that it will patent and it is not going to collapse during sleep. So it helps to expansion of the airway, or we can stabilize the airway, or we can remove some tissue which gives some obstruction in the upper airway. So how the sleep endoscopy help us to decide, is my patient is a good candidate for surgery or a non-surgical candidate? Is my patient is getting a single level or the multi-level collapse? What type of collapse is getting? Is it kind of a lateral collapse, anteroposterior collapse, or it's a concentric collapse, or we can call it triangular collapse? I'll go through this one in the subsequent slide. Or any change in the collapsibility of the airway during sleep position, supine position, the right lateral, left lateral position, even the tongue base position in a supine with the jaw thrust, or even in the left lateral position, we can understand that. Even we can see the tone of the upper airway. Is the patient having a well-maintained tone of the airway, or patient having hypotonic airway? When we are looking a little bit down in the supraglottic area, we can check for the epiglottis. It's a collapsibility. This was one of the hidden area which was not well evaluated before sleep endoscopy introduced. And also we can see, is there any collapsibility of the supraglottic laryngeal framework? To add on more, it helps us to identify the non-obstructive events. Even we can pick up the central apnea when we perform the sleep endoscopy. Those patients already underwent surgery for upper airway, so the sleep endoscopy helps us to find out what would be the cause for the failure of the sleep surgery, or to find the reason for the CPAP, as I said before, why the patient is not able to tolerate or why it doesn't want to accept, why we need a high pressure to keep the air passage patent. Also, it helps us to understand, is my candidate patient is a good candidate for oral appliances, and to decide nowadays for more than a decade, it helps us to take a decision about hypoglossal nerve stimulation, especially for the Inspire and the Livanova. But the Genio, that's a Nixova, they said for even for the concentric collapse, they can use the nerve stimulation because it's a bilateral stimulation. In that, even the concentric collapse can be managed with the Nixova. And last but not the least, I can say that most of the patients turn up to us with the snoring problem, and on the sleep study, we can pick up that they might have the upper airway resistance syndrome, and the sleep endoscopy help us to understand where exactly the patient having a problem, from where the patient having a snoring problem, can we fix that problem. So about the sleep endoscopy, it has to be performed in the operation theater. The duration, as per the literature, they mention 5 to 15. But when we do really comprehensive sleep endoscopy, it takes around 15 to 45 minutes. We do under deep sedation given by the anesthetist. We put the big spectral index. We keep the sedation or the depth of sedation is from the 70 to 50. That is goes close to the sleep. As per the position paper, currently they use a propofol midazolam, but we routinely use the dexmedetomidine. And with the midazolam, that goes to more natural sleep. And when we perform the sleep endoscopy, we document all this finding as per very well accepted classification or the table. That is a VOTE classification, V for velum, oropharynx, tongue base, and epiglottis. Here you can see first two. This is about the velum. That is the base tongue area, and that's the epiglottis. And where you're going to document degree of obstruction, partial or complete. Is it an anterior posterior, lateral collapse, or circumferential collapse at a different level? But when we dealing with the pediatric population, as per this article, very well published, they mentioned that we don't need just VOTE, but we need beyond VOTE, V for velum, oropharynx, tongue, epiglottis. Definitely we have to check and document in the pediatric age group. Along with that, we have to look for the nose in the pediatric, especially the hypertrophic turbinate, some significant deviated septum, or any abnormality. Very important, that's adenoids is one of the most common cause of sleep apnea in a pediatric age group. And beyond the epiglottis, we have to look for any laryngeal abnormality like laryngomalacia. So this article says that just not using the DISE to document as a VOTE classification, but as per this 47 article, they mentioned that we need to consider the descriptive assessment of the DISE finding that help us to make a right decision to pick up the appropriate surgical treatment for the patient. What is descriptive classifications? Beyond the VOTE, we are always look for, is it a palate get collapsed primarily, or what kind of a collapse patient is having at the retropalatal? Is only anteroposterior, is it lateral, or it's a triangular? Is it because the palate is collapsing primarily, or it is pushed back by the muscular tongue base? Hypotonic muscular tongue base is pushing the palate backward. When we are looking at the oropharynx, we always think about lateral collapse, but also we need to consider the palatal and tonsil, or is a combination of the lateral collapse along with the palatal and tonsils. In terms of the tongue base, it can be a primary collapse. It's a tongue is collapsing, or it may be a huge lingual tonsil sitting at the base tongue that may be responsible for the tongue base collapse. When we are looking at the epiglottis, we always think about it's a trapdoor collapse, but it can be a secondary collapse because of the lingual tonsil or the vertical position, muscular tongue is pushing epiglottis backward, are also array epiglottic fold pattern of the collapse. So there is always a debate about drug-induced sleep endoscopy versus the Muller's maneuver. Muller's maneuver means we perform the upper airway assessment with the endoscope in the clinic setup. During that, we pinch the nose and we suck the patient air inside, and with the endoscope, we try to see that which area is trying to collapse. But with this comparative study, they realized that the DISE finding and surgical outcome is having the better success rate as compared to the Muller's maneuver, because DISE gives the real-time assessment of the airway collapsibility. So in 2023, I wrote one articles, and we picked up the moderate to severe obstructive sleep apnea patient having a significant nasal blockage. We performed the sleep endoscopy. We noticed that patient having a multi-level collapse at the level of velum, oropharynx, base tongue. But however, side by side, they have a significant blockage in the nose. So we performed the DISE with a significant blockage in the nose. We just did the nose surgery for those patients, volunteer, and we repeat the DISE after 3 months of nose surgery. Also, we managed to do some sleep study, and we conclude that, and we come to know that just addressing the significant blockage in the nose, it will change the collapsibility pattern at the level of oropharynx and some changes at the level of epiglottis. So that also raises a question about those patients having a significant nasal blockage. Really, we need to proceed with the multi-level surgery, or first we perform the nose surgery, and at interval, we can repeat the sleep study or go ahead with the sleep endoscopy. Now, this is a systemic analysis or review of almost 1,500 patients, and they realized that those patients underwent upper airway surgery guided by sleep endoscopy have a lower failure rate, approximately 37%. So DISE has a role when we are talking about the invasive treatment for the patient. Now let's go to what are the various patterns we picked up when we perform the sleep endoscopy. Of course, we go with the Vogt classification, that's velum, oropharynx, tongue base, and the epiglottis. Here is going through the velum. First, you can see that how the anteroposterior collapse is happening at the level of velum. You can see how the primary lateral collapse is happening at the level of velum and the oropharynx. So just by doing the traditional UP3, this is gonna helpful for the patient with the anteroposterior collapse, means uvulo-palato-pharyngoplasty. But definitely this patient is gonna have a failure if I do a traditional uvulo-palato-pharyngoplasty, because they have a lateral collapse. On top of that, when we do the detail assessment, you can see the patient is having a triangular collapse. Here, not only the anteroposterior, but also the lateral wall involved. Sometimes we get the reverse triangular collapse pattern, and that is most likely because of the endophytic tonsil that pushes the palate backward, and that gives the impression of the reverse triangular collapse. When it comes to the tongue base, you can see there is an active tongue base collapse that blocking the air passage. And sometimes because of the hypotonia, even the tongue is bulky, but slowly fall off. Maybe the box is not adequate to accommodate the tongue. So one of the reasons for the failure of the tongue-based surgery is not properly evaluating, is it a primary collapse of the tongue? Is it a muscular tongue? Are we dealing with the fatty tongue? Are we dealing with the hypotonic tongue? So that is very important to understand before we offer surgery and to get the better outcome. When we come to the epiglottis, the Franchi and Dr. Rudolf Lugo come up with the classification, and they discuss about the different pattern of the epiglottis collapse. Otherwise, we always talk about the partial and complete collapse. But first, they come up with the trapdoor in 50% patient when there is an anteroposterior collapse, most likely because of the floppy epiglottis. Lateral collapse, we always document as a omega shape, but it's called as a lateral collapse. They define as a book type. It can be secondary to the lateral pharyngeal wall squeezing the epiglottis, or the tongue base is squeeze the epiglottis in around 25%. So they picked up 4 different types of classification of the epiglottis collapse. So here you can see that classically there is a trapdoor collapse of the epiglottis. And this is the lateral or book type of collapse. See, that's the primary. Even you can see the collapse at the level of well. And there is a partially, the epiglottis is pushed backward by bulky tongue. Beyond the epiglottis, when we are looking at the hypopharynx, you can see that how the supraglottic area is completely squeezing aryepiglottic fold, arytenoid cortical lateral pharyngeal wall. So it is not just epiglottis, it is a supraglottic collapse as well. And one of the reasons for the redundant mucosa in that area is the gastroesophageal reflux disease. Above the Vogt classification, so there is a new grading system come up called the salpingopharyngeal fold, which is present in the nasopharynx, is written in 2019, and they put it as a 3 grade, 0, grade 1, and grade 2 when complete collapse. And here is the video. Here, that's the level of the velum. It's a retropalatal area, and these are the palatopharyngeus, salpingopharyngeus fold. This is grade 1, salpingopharyngeal fold. They are partially contributing in the collapse of the level of velum. And here, this is a grade 2. They are significantly contributing in the collapse of the soft palate. Not only the collapse, but we also have to look for the redundant mucosa. In this patient, you can see that we can get an impression that the soft palate is collapsing retropalate, but mostly the redundant chronic inflamed edematous mucosa is responsible for the collapsibility of the airway. Sometimes not just a palate collapse anteroposteriorly, but there is inward rotation of the uvula into the nasopharynx, and that gives the fluttering sound, snoring sound, because there are two schools of thought, preservation of the uvula versus removal of the uvula. So if we go with the partial uvulectomy, of course, not cutting the uvulus muscle significantly, we can give a good result just by getting this finding. Now, the sleep endoscopy is not just related to look for the collapsibility of the airway to define any surgical treatment for the patient, but just by doing a simple jaw thrust, you can see that the airway is quite open, square pattern without any collapsibility. Patient breathing comfortably, apnea has gone. The time we relax the jaw, see how the hypopharynx is open very well, tongue is sitting very well. And the time we release the jaw, see what's happening. Now again, patient started mostly antero-posterior collapse with the snoring sound. Even I'm showing the clip of half minutes or 30 seconds, but whenever we do any maneuver, we have to wait for 1 to 2 minutes for the patient to fall into the proper sleep cycle, and then we record the finding. So this is another way to assess how the oral appliances can help the patient. I'm doing the Ishmarch maneuver. In that, we have to pull the jaw forward around 70% of the jaw movement, and that also give me an impression that there will open significantly just by doing Ishmarch maneuver, and that gives me an impression that my patient will get benefit not by the surgery but by the oral appliances. And also there is a device called a SAM device, quite sophisticated, expensive, and that gives the exact numbers, how much we have to advance the jaw. Is my patient is a good candidate for the oral appliances or not? So DISE help me to understand, is my patient is a good candidate for the oral appliance or not? Another thing, we get the more information about the tongue-palate interaction, because we always think the palate is the primary collapse. It can be a secondary collapse because of the tongue might be pushing back palate backward. Here we got to understand that which is the most vibratory area of the palate making the sound. How is the relationship with the tongue? Is the tongue is getting fold? So by doing the DISE, when we pass the camera through the mouse, we can get the understanding about the relationship of the soft palate uvula with the base of the tongue, how it vibrates. Not only the sleep endoscopy stuff here, but during sleep endoscopy, we can also do the CPAP titration. I would like to very thankful to Dr. Rudolph Lugo. He allowed me to share this slide. We were doing a lot of CPAP titration when I was with Professor Rudolph Lugo, and we edited very well. That's why I'm putting this one. So when the patients start using the CPAP machine, at least for a month time, we come to know that how much is the optimal pressure, 95th percentile pressure required to open the airway. And that's what we consider. It's a maximum pressure 12 centimeter. And what is the lowest pressure? So by doing the CPAP titration, we also come to know how much is the peak rate pressure for the airway collapse. So slowly we drop down the CPAP pressure from 12, 10, 8, 7, and the 6. Once it comes to the 6, the airway start collapsing. And when the pressure is at 12, the airway opens up. So the DISE not only help you to understand the upper airway collapsibility, but also help us to titrate the CPAP as well. I would like to share this very interesting case. This is the middle-aged gentleman, severe obstructive sleep apnea, on the CPAP machine, cannot tolerate. He always choke whenever he uses the CPAP machine. He has to wake up, he has to take out the CPAP machine. Pressure goes very high, 15, 16. The air leak from the mouth, he cannot able to expire. When I perform the sleep endoscopy, you can see that he's having the collapse at the level of the velum, but also you can see the epiglottis is collapsing significantly like a trap door. And whenever he is putting the CPAP, that CPAP, it is still pushing the epiglottis downward. It is not squeezing like a book type, but also it's going anteroposteriorly. So this patient definitely will get the benefit by doing some surgical intervention. Now let me quickly take through some interesting slide over the diagnostic DISE, how the DISE is gonna helpful. So whenever we see it's kind of a palette. Sorry for the interruption.
It is okay.
All right.
And I do
All
have
right.
to, oh, there you go. It started.
Oh, you got it. Okay. So how we remove the tonsils, you can use any technique. Once we do the tonsillectomy, it is very important to check for the posterior pillar. That is very important. That's the palatopharyngeal muscles. After that, we have to point out the posterior nasal point, intermediate point, supratonsillar fat pad, and pterygomandibular raphe, where we're gonna suspend the palate. So the things have changed from the traditional UP3 to the suspension bar of pharyngoplasty because we start seeing the collapsibility of the airway. Here I am doing the supratonsillar fat pad. From the right side as well as from the left side, you can use monopolar, you can use coblation. And here I'm releasing the palatopharyngeal muscle to pull it upward and laterally. Or sometimes we can just mobilize the palatopharyngeal muscle, that is also named as the posterior pillar, laterally and upward to create more space in the retropalatal area. For the elongated uvula, we will gonna cut it, excess of mucosa without damaging uvulus muscle. And then we use the barb suture. This is a PDS suture. Lasts for around 90 to 180 days. Is 30. It's one-way suture. We don't have to put the knot. We start from the posterior nasal spine, come to the intermediate, and try to suspend the whole palate to the palatopharyngeal muscles so that during sleep time it is not gonna collapse and obstruct the airway. And here we're gonna pick it up, palatopharyngeal muscle, and all the way gonna pull it towards the pterygomandibular raphe. That is the most strongest structure where we can suspend the palate without damaging, without creating the scar over the mucosa. And that's how it looks like post-surgery. And that is after 6 to 9 months, you can see the normal palate without tonsil, but it looks like it's very well suspended by the scars. Now, when we come to the situation, the patient is having a glossoepiglottis or epiglottic collapse, trapdoor, we do glossoepiglottiplexy by using the copulation. We are trying to create the scarring between the epiglottis and the base tongue. So of course, the scarring followed by fibrosis, it contracted and it lift the epiglottis forward toward the base tongue and reduce the chance of collapsibility. Now, let me take you through how the interdisciplinary management is going to happen when the patient come to the clinic with the history of snoring, or when we come up with some sleep related disorder, either to the sleep clinic or the ENT clinic. Depends on the primary history, family history of high blood pressure, diabetes, overweight patient, psychological problem, or having some neurological issues, or patient having overlap syndrome. In itself, in the first consultation, we can send patient to all this interdisciplinary team. Of course, in a suspicious patient on the Ipper sleepiness score and the symptomatology, we will have to do the level 1 and level 3 sleep study. Of course, we do the detailed examination of the patient. If we picked up high arch palate, tongue tie is there, and because of the tongue tie, the tongue muscles are very weak. Most common finding missed by most of the sleep surgeon or the new surgeon or the ENT surgeon is the tongue tie. If it is the tongue tie is there, the tongue muscle is not gonna develop, it's gonna weak. So even we release the tongue tie, it is not gonna sit because it keep in hold for the years together. That's why the role of the myofunctional therapy come into the picture. Whenever we see any patient with the tongue tie, has to be involve the speech therapist. If we picked up the high arch palate or any dental crowding, malocclusion, dentist has to be activated. On ENT point of view, if we see the gross deviated septum, chronic sinonasal pathology, nasal polyps, hypotropic turbinates, of course, we have to do the definitive treatment. On the sleep study, if we picked up the central apnea, restless leg syndrome, we need to refer a patient to the neurologist. For a patient having a moderate to severe obstructive sleep apnea, along with the sinonasal disease, definitely we offer sinonasal medical treatment or the surgical treatment. Or we offer the CPAP, that is the recommended treatment at this moment, along with the lifestyle modification in terms of the reduce the smoking or quit smoking, no alcohol, follow the sleep hygiene. Positional therapy is also important. When we see that sleeping on the right lateral, left lateral position, the apnea index drop by 50%, we go ahead with the positional therapy. Speech therapy and the myofunctional therapies is very important. During in the clinic setup, we use even the weighing spoon to measure the tone of the muscle and how the muscle is weak. If the tongue is not able to push your weighing spoon more than 100 grams, your tongue is hypotonic, and this patient really need myofunctional therapy. We need to start at the beginning itself. When we see that the tongue is not strong enough, it is not able to even push the spatula, we have to start doing that myofunctional therapy to improve the compliance with the CPAP. It makes the tongue in the right position during sleep. It also helpful when we do the tongue tie release. Myofunctional therapy should be there. If we find that significant sinonasal disease, we perform the sinus surgery. We wait for 3 to 6 months, and if there is a need, we repeat polysomnography if still patient present with the persistent symptoms of sleep apnea. If there is a residual OSA, of course, we do the CPAP. But moderate to severe sleep apnea is there. But if you realize that patient is a good candidate for the oral appliances, definitely we can give the trial of the temporary appliances, or if definitely in term of we can give the permanent mat device. But if we give the trial of the MAD, we can repeat the polysomnography after 3 months with the mat, or even we can use the Snore Lab application. It will help us to record the snoring sound, or also we can use the any particular applications or the smartwatch to check for our oxygen saturation while using the mat, that help us to understand the compliance and the use of the MAD to resolve the obstructive sleep apnea. But if the patient having a poor compliance with the CPAP, of course, patient turn back to the ENT clinic to find out the other possible reasons and help. In that case, we can perform the drug-induced sleep endoscopy. So if the patient turn back to all this internal medicine or the psychologist or neurologist, of course, they can refer back to the ENT clinic or the sleep clinic to perform the sleep study. Pulmonologist can do the sleep study very comfortably and they can give the CPAP, and they realize that patient having some poor compliance with the CPAP and there are some other issues with the CPAP, they can refer to our clinic to perform the sleep endoscopy. The sleep endoscopy gives us the idea about the dynamic collapse of the airway. On the basis of that, we can offer the soft tissue surgery, tongue-based surgery. Nowadays, there is a role of the hypoglossal nerve stimulation. On top of that, I can say that if we picked up the central apnea, we can involve the neurologist. If we do the Ishmael maneuver or the jaw thrust, we can refer patient to the dentist to provide the oral appliances. If you realize that the tongue soft palate is the hypotonic, tongue base is hypotonic, we definitely involve the speech therapist after the sleep endoscopy. It also helps us to decide do we need to perform the single stage or multi-stage surgery. And once we perform any kind of surgery, again patient has to go back to the lifestyle modification, positional therapy, and the myofunctional therapy. In terms of the myofunctional therapy, if we introduce the myofunctional therapy 2 weeks before oral surgery, even the parallel surgery or tongue-based surgery, post-surgery, if we start doing the myofunctional therapy in 1 or 2 weeks time, it will help to heal all the scar and the upper airway remodeling space in a physiological way, and it helps to strengthen the muscle to keep the air passage open. Even the myofunctional therapy helps to improve the compliance and reduce the fall of the tongue-based area. Of course, post-surgery, we need to involve the dietitian. Even with the CPAP, we have to involve the dietitians to make sure that the patient BMI should be under control. And after the surgery, depends on, are we curing the condition? Are we reducing the severity of the obstructive sleep apnea? Are we dealing with the patient with the severe apnea with the comorbidities? 50% patient usually go back to the CPAP machine with the support, or they go with the oral appliances, or they can go with the lifestyle modification or the positional therapy. As the disease of the obstructive sleep apnea changes with the age, with the comorbidities, lifestyle, BMI, so we have to keep on evolving all interdisciplinary team to understand where exactly my patients stand, who is gonna helpful at what stage of the disease. To conclude, to my presentation, to say that one size fits CPAP to the multidisciplinary, or I can say the interdisciplinary management of the OSA is the current era or a time to management of the obstructive sleep apnea. All the CPAP failure patients or the poor compliance patient has to be evaluated by the sleep physician or ENT to bare minimum to offer the sleep endoscopy. It is not just an examination. I would say it is the comprehensive procedure to define the proper treatment plan for the patient. It helps us to understand the multifactorial cause for the severity of the OSA. We can offer the upper airway surgery, but patient should go with the DISE unless we see any obvious obstruction like deviated septum, hypertrophic turbinate, or the huge tonsils. To add more, don't just label as a VOTE classification, but we have to see the different patterns of collapsibility, behavior of the upper airway mucosa to decide the methodology of the surgery. Even for the simple palatoplasty, there are 5 to 7 different types of palatoplasty we can perform as per the collapsibility. In the pediatric, we need to involve the nasal, adenoids, and the laryngeal. In case of the primary OSA surgery failure, its morbidity and the reassessment, DISE works significantly, not only the clinical but also the medical legal purpose. I would say that still there is a position paper release. A lot of our literature is there on the DISE, but the methodology of the DISE is not yet well structured. It is not the universal to read the report to say that this treatment can be followed. So because it is quite significantly influenced by the anesthetist, the surgeon, experience, the procedure, how they do it, patient factors. So if we go ahead with some objective analysis of the diet, that's a food for thought. It allows us to understand its role in a patient selection and to improve the surgical outcome. So with this, I'd like to say thank you to the Airway team to give me this opportunity to have a discussion about the role of DISE in the management of obstructive sleep apnea and interdisciplinary role in it. I'm very fortunate. These are my trident, Professor Manuel Casale, Offer Jacobis, and Rudolf Lego. And very fortunate for me too. We are coming up with the third edition of sleep apnea snoring. And I'm very happy to write a chapter with offer on bar pharyngoplasty in this. And thank you very much for your attention. Thank you very much, Ranta.
Wow.
Thank you very much.
Standing ovation right now. This is seriously the best DISE lecture that I have seen so far. And it is so much needed in my field. I just messaged my team. I was like, this needs to go into our course. So thank you, thank you, thank you. I mean, to be able to see all these different DISE videos and how it's collapsing, it is so crucial for any myofunctional therapist or dentist who is dealing with any patients with OSA. We need to be able to see that and understand that, and most of us don't. So thank you for sharing this from your perspective. Absolutely. I have so many questions, but let's just use
Please go ahead. I'll try my best to answer.
All right. And anybody, please, if you're here live, send us your questions. Let's take a look. My first one, you mentioned coblation versus complete removal of tonsils or adenoids. Can you talk a little bit more about that? What is the difference? When would you choose coblation? When would you choose it would be complete removal if it's not coblation? No. Cutting it.
Okay. So basically, the coblation is one of the technique.
Okay. So yes, it burns it, right?
Yeah. It's use the plasma field. So if I use the cautery, the temperature goes around 400 to 500 degrees Celsius. It's very traumatic. Coblation, it creates a plasma field. It melts the tissue. Temperature is around 40 to 50 degree. It has a learning curve, but the healing process is fast. In terms of the adenoids, I can say that till the time most of the doctors, they do the conventional curettage of the adenoid. They just blindly feel the adenoid, curate it. That's why the recurrence is very high. But if you do endoscopically, if you see the adenoids and you use the coblation, we remove 100% adenoids. And with my experience in last 7 years, not a single child turn up with the recurrence of the adenoids because we remove a box type of the adenoid from the nasopharynx. In terms of the tonsils, technique doesn't matter. The person behind the tool is very important. I'm comfortable with the coblation because it's a bloodless. My tonsillectomy finished within 5 to 7 minutes. Zero blood. It's called as a bloodless tonsillectomy. Doesn't matter I'm using the cautery or cold dissection method. Why coblation I prefer? Because I get the plane better. I get the magnified view if I'm using the loop, and I can save the palatopharyngeal muscles. Renanda, I can say that it's just a tool, coblation. But you can use any other instrument, whichever you are comfortable. Adenoids, if you ask me, I go 100% with the coblation because that's a beautiful instrument for the adenoids, I can say, even for the tongue base.
Thank you. So those are different techniques. And then if you are going to remove all of the tissue or just reduce them, you can do that with any technique. It's going to be up to the surgeon to choose.
Yeah. About the tonsils, when we are planning to do the palatoplasty surgery, we need to expose the palatopharyngeal muscle. That is the posterior pillar. And for that, we have to do the tonsillectomy. But if I'm dealing with the pediatric age group, gigantic tonsils, I just want to open the airway. In that case, I am going to do only tonsillectomy. I'm going to just shave up the tonsil with the coblation. And I keep a small layer of the tonsillar tissue at the bed of the tonsillar. So it reduces the chance of the bleeding. But honestly, if I do tonsillectomy, blooding percentage is 1 to 3%. If I do tonsillectomy, remove some tissue behind it, percentage is around 0.5 to 1%. It's just a matter of 1 to 2%. So again, it's all about the choice. But adult tonsillectomy is preferable.
Perfect. So afterwards, so the post-op, How is the patient comfort, or is there anything differently that they have to do depending on the technique that you used?
Absolutely. So let's talk about one. If I'm doing the palatoplasty for the patient, if I'm doing the palatoplasty for the patient, if the patient having a moderate to severe obstructive sleep apnea, we ask patient to start using the CPAP on the same night. So
Okay.
because of that, patient is not gonna snore with the suture palate. So my suture is not gonna break down. With the CPAP, patient breathing comfortably. That is one.
Mm-hmm.
So we start introducing the CPAP on the day one. We have to really take care of the pain post-operative, and we do not ask patient to eat a solid food because I don't want too much dynamism in the soft palate. Because I'm repositioning the palate, I'm not cutting the palate. What we practice routinely in a 1 week before, we ask patient to start doing some tongue and palatal exercises, where you guys come into the picture. Because patient, I'm gonna change the anatomy, topography of the
Mm-hmm.
palate. So patient is having a problem with the swallowing, eating, and they eat, swallow very differently. They got some regurgitation. If I introduce exercise 1 or 2 weeks before, it is not only make the muscle stronger, but patient knows that how to use the muscles and all. So there is some
Mm-hmm.
memories. So post surgery, within 3 to 5 days, I ask patient to start doing some exercises for the palate and all. It is allow the palate heal in a natural way with a more
Mm-hmm.
dynamism and the less pain, less inflammation. I think we have noticed there is a better healing as well. So yes, there is a role in that, and more on the tongue base. When I'm dealing with the tongue tie, 2 weeks before we introduce the tongue exercises, because patient, once I cut the tongue, it's a painful, they stop doing exercise. So two
Mm-hmm.
weeks before, I ask patient to start doing the tongue exercises regularly. They go to my dentist, they also introduce the various exercises. If I do the coblation tongue base, they need to know that how to do the exercises and all. That will helpful.
Exactly.
Better the tone, they sit in the mouth, otherwise they're gonna fall in the airway. That's
Mm-hmm.
how we learn over a period of time.
Very good. Oh my goodness. How about post-op bleeding? Which technique has more risk for post-op bleeding of the
Okay.
tonsillectomy?
Okay, so about the tonsillectomy, as per the evidences, coblation technique have the more risk of bleeding over the conventional way. But I think it's a learning curve. So if I'm using the coblation for first 25 patient, out of that, 5 patient is gonna bleed,
Mm-hmm.
because it's all of the technique, how you're gonna burn it, how much time you spend. Next 75 patient, not a single bleed you're gonna notice, because you know that how you're gonna use your wand in between. You're not
Okay.
gonna burn the tissues. I think that is one of the reason the percentage of the coagulation is a bit high in terms of bleeding. Second, what I noticed that in which patient are we using? If I'm using coagulation in a pediatric, chances of bleeding is very negligible. But if I'm using coagulation in the adult,
So,
chances of bleeding is very high because of vascularity, infected tonsils and all. So depends on which category of the patient using which technique, it's all matter. But
okay.
till date, consensus says conventional is always better over the coblation or electrocautery dissection method.
Somebody mentioned bovine cautery on low 10-watt setting or coblator, depending on the circumstances. One of my ENTs, when I asked about
Okay,
the use of a
right.
diode laser maybe on the tonsils.
Okay. So honestly, I don't have personal experience with the diet. But about the coblation, very simple. For the
Okay.
adenoids, I put the setting 8 and 4, 8 for ablation and 4 for coagulation. For the tonsil, I put the setting 7 and 3. 7 for ablations means to cut, and 3 for coagulation. If I'm doing the base tongue, again, I go with the 8 and 4. I
Okay.
suggest my ENT colleague, before you touch the base tongue with the coblation, you have to do at least minimum 50 adenorectomy with the coblation to understand
Okay.
how you deal with the tissue. So yes, you need more coagulation when you are dealing with adenoids and the base tongue as compared to the tonsils. Cautery setting is around 20-25, bipolar and
Okay.
monopolar. It depends on what you want to use. But I
Perfect.
use bipolar if you want to use. I don't use monopolar, honestly speaking, for the tonsils.
Okay.
No problem.
When is it necessary to do base of tongue, in your professional opinion?
Okay. When we see the obvious enlarged lingual tonsils, I think we should work on that. When we're in the Singapore, honestly speaking, we do multi-level surgery. We do a lot of tongue-based surgery, but the tongue-based surgery number has reduced exponentially. Now, what are the indications I do have? Enlarged lingual tonsils. That is not gonna go. Second, the tongue base collapse is most 50% patient is because of the box. The jaw is responsible for the tongue base collapse. Now the oral appliance is coming into the picture. My jaw is falling back. When I'm breathing through the mouth, my jaw goes back and my tongue falls. So we were fixing that one, but the outcome was not good. Now I realize that moving the jaw forward, tongue is not gonna fall. So it reduces the tongue-based surgery. Second, the tone of the tongue. If a tongue is weak, even you do excellent tongue-based surgery, it's gonna fall. So again, another 20 to 30% of the tongue-based surgery is reduced because of just introduction of the myofunctional therapy. I can say that. Just doing the exercise that will keep the tongue 1 to 2 millimeter forward. It improves the tone of the tongue during sleep time, and that's worked wonderfully. Of course, the bulky tongue, huge tongue, it occupying the valvula. In that case, we do the coblation tongue base, or we can do the radio frequency channeling to make the tongue a little bit more harder. That's how. So if you ask me, the surgery for the tongue base has been reduced because of the introduction of the oral appliances, myofunctional therapy. Now the hypoglossal nerve come into the picture, but it is very super expensive, honestly speaking.
Yes.
So yeah, so it's a luxury, I can say.
Do you see a correlation of enlarged lingual tonsils and all the other soft tissue enlargements that are more normal that we deal with? So tonsils, palatine tonsils, and adenoids.
Yes. It's called as a Walder's ring, internal Walder's ring. These are all the fascial tonsils. We have a lingual tonsils, palatine tonsils. You have adenoids. There are a lot of lymphoidal tissues are there. So those patients having allergic or they are sensitive, they have a quite enlarged tonsils. It is very commonly we see that those having a big tonsil, they also have a grade 1, grade 2 lingual tonsils as well. But along with that, if you see any child with a huge lingual tonsils, with the big tonsil, with the posterior triangular lymph node, I preferably keep a low threshold to do the peripheral smear to rule out the lymphoproliferative disorder. But if the patient is a smoker, and chronic snorer for 5 to 10 years, right, and those having a chronic allergy, it is very commonly we see the big lingual tonsils. It's quite common finding. And that is responsible for the secondary collapse of the epiglottis.
Yes, I've been seeing some on the CBCT. So as a myofunctional therapist, whenever we see those in the images, we can contact an ENT surgeon and say, please evaluate lingual tonsils.
Absolutely.
And it is, so there's a way that they can do coblation only on the lingual tonsils without cutting the tongue at all?
Absolutely. It's just a matter of 10 to 15 minutes. We just melt out the lingual tonsil like an adenoids. Up to the base, we are without touching the muscles, and that makes a huge difference. And that create the scar that hold the tongue very well. And it helps us to reduce the space in between the tongue base and the epiglottis as well.
Awesome.
So
and they don't tend to grow back.
Usually they don't grow back because we create the scar, and once we take it out, there are of course some lymphoidal tissue, but that they are not gonna grow that big.
Amazing. I can sit here and pick your brain for an extra hour because I have so many questions, but I'll be respectful of everybody's time. Thank you so much. This has been so eye-opening, and I know it's going to help so many patients by sharing this information with our multidisciplinary group, with other professionals that are seeing these patients, so they can find surgeons to collaborate with. And would you like to share one more time, how can people find you?
So they can go to my website, drshaileshkhode.com. Even they can put my name, Dr. Shailesh, in the UAE, Middle East, you can find me. So we're gonna start providing service to the Abu Dhabi, Dubai, and also in Aligned, 3 Emirates, to start with the interdisciplinary approach toward the management of sleep apnea.
That is absolutely incredible. Well, thank you so much for spending this time with Airway Circle today. And I hope everybody has a wonderful day. Thank you.
Thank you very much. Thank you, Ranta, for this platform.
All
Good
right,
night.
bye-bye.